Awesome. So we are at 9:40. Good morning, 9:40 Central Standard Time. We have some guests today that are in different time zones. So I'm going to introduce our team. So welcome as everybody's coming in. First is Dr. Michelle Walter. Michelle trained in internal medicine and pediatrics, and then did a hospice and palliative medicine fellowship. She's worked in a variety of different locations: home-based palliative care, hospice for adults and children. I love the pediatric component here. We don't see as much of that, of course, so this is just wonderful. Doing inpatient and outpatient medicine. She was most recently at the Roswell Park Cancer Center in Buffalo. And then there she was an associate professor, received fellow status through AHPM. Congratulations.
Thank you.
She was the program director for the HPM fellowship at the University of Buffalo. So clearly an engagement with teaching and medical trainees. Recently, Michelle is undergoing some career changes, adaptations. She's doing a life coaching business, working as a coach and mentor to medical students, which is such a great opportunity through the University of Buffalo. She does have her own business now, miravistacoaching.com, which is really cool. So that's Michelle. She's going to be presenting a paper that she just recently published. I'm going to also introduce Dr. David Currow as well. Dr. Currow is also a physician, currently the Deputy Vice Chancellor at the University of Wollongong. I hope I pronounced that right. Excellent. So from Australia. So this is super exciting. Dr. Currow has been gracious enough to get up or maybe not go to sleep, but to be up in the middle of the night to talk with us due to the time zone changes here. Dr. Currow is widely published with research in reducing the burdens of cancer, symptom control, and population prevalence and impacts. So also health services research. He was previously, and I don't know, you're going to have to help me. What is NSW, Dr. Currow?
New South Wales. It's the state where I live.
Okay, perfect. New South Wales Chief Cancer Officer and the Chief Executive Officer of the Cancer Institute in New South Wales. He's also the Foundation Chief Executive Officer of Cancer Australia. He was elected as a Fellow of the Australian Academy of Health and Medical Sciences in 2015 and a Fellow of the Royal Society of New South Wales in 2024. And I think most of us here will have to apologize and say that a lot of those societies are not ones we're quite as familiar with, but this all sounds really impressive. So we're delighted to have both of you on today. I did want to note here, Marty's just posting too, there is no CME today. There were just some administrative issues with that, so you don't have to text in your code today. We are planning to have Michelle talk for a few minutes about her paper. Dr. Currow, David had wrote in a letter in response to that regarding octreotide use, so he's going to talk a little bit about that. And then we're hoping to still have about 10 to 12, maybe 15 minutes or so at the end to talk about any questions everybody has, or to let David and Michelle just talk a bit about their respective works. So with that, I'm going to let Michelle get started.
All right, thank you so much. I have my slides. Hopefully this works. All right, so I am going to talk about my paper, our paper, my team's paper, Palliative Management of Inoperable Malignant Bowel Obstruction. And this was a prospective open label phase 2 clinical trial at Roswell Park Comprehensive Cancer Center in Buffalo, New York. The paper was published in JPSM in January of 2024. So let's see. Okay. So this is important for, a variety of reasons. Malignant bowel obstruction is relatively common, in particular in gynecologic and colon cancers, but really any cancer that causes intraperitoneal disease can cause a malignant bowel obstruction. And the symptom burden is really high. I mean, these patients are miserable. They have pain. They have nausea and vomiting. They're not moving their bowels. They're not eating or drinking. Oh, sorry about that. Okay, and yeah, it's just really high symptom burden when patients are experiencing an obstruction. And, the consequences of a malignant bowel obstruction are pretty serious. So if the obstruction does not resolve, patients are not able to eat or drink orally. That has cultural significance. It has dignity significance. And patients may make a decision to accept TPN. It has its own burden and risks associated with it. So a lot can be involved in a malignant bowel obstruction, not just the symptoms. As we're going to talk about multiple times probably today, the prognosis associated with a bowel obstruction is really poor. These patients, we'll talk about it with the paper. And then, you know, there are many pharmacologic strategies in the literature, you know, looking at how best to manage the symptoms and the obstruction. And that includes steroids, octreotide, olanzapine, metoclopramide, Haldol or haloperidol, ranitidine, in addition to all sort of the standard of care things with bowel rest, fluids, and NG decompression. The patient population we're talking about today are those with an inoperable malignant bowel obstruction. So these are not patients that are eligible for surgical intervention or procedural intervention because of either their comorbidities or the type of obstruction that they have. Despite all of the literature that there is, there's really no consensus on what is the best management strategy. Right. So again, this is a prospective study. We were really looking, the primary endpoint that we were looking at was de-obstruction. Can we resolve the bowel obstruction with our medication regimen? And some of the secondary endpoints that we were looking at were symptoms, tolerability of the regimen, and survival or prognosis. So our patients were evaluated to make sure that they weren't eligible for any kind of interventional procedure, a stent, or surgery. So they were considered to be inoperable. And when the patients consented to the regimen and to the study, then they were started on what we call triple therapy. And that was octreotide, metoclopramide, and dexamethasone. And our team had looked at these three medications previously and published a retrospective review back in 2021. Again, trying to find, you know, is there efficacy to resolve the obstruction and what effect do these medications have on bowel obstruction? And because of the variability, you know, it being a retrospective review, we weren't able to make any great conclusions from that. So that was one of the reasons that we wanted to study these medications prospectively. There was another study by Berger et al. In 2016 that also looked at just these three particular medications in combination. And they had results with 100% resolution of nausea by day 1. So sort of optimistic results that this regimen can be helpful. And then we also looked at, you know, what are the guidelines? What is the literature out there about these meds in the setting of malignant bowel obstruction? And it's not great. There's really not a lot of great evidence. There's a lot of mixed results, you know, some supporting, some not. And we did review the one sort of panel guideline from, I'm going to get this right, the Multinational Association of Supportive Cancer Care, I think is the MASCC. And they have guidelines, and their recommendation is actually the highest for octreotide at a level 1A. So that's the highest evidence and highest recommendation for using octreotide in malignant bowel obstruction. And the next best evidence is for both metoclopramide and a corticosteroid like dexamethasone at level 3B. So this is not like stellar evidence, but this is what we have and what we were working with and why we decided to choose these meds. So our results, de-obstruction. So we only had 15 patients and enrolled, and I'm going to talk about that in a little bit. 13 of our patients completed the study, and of those 13, 10 de-obstructed. And the de-obstruction rate was 73%. Unfortunately, this was not statistically significant. And then we had 2 patients that discontinued. I think a key piece of information here is that the median time to de-obstruction was 6 days. And I think experientially, we knew that sometimes patients de-obstruct really quickly. within 1 to 2 days. But often we find that it takes multiple days for those symptoms to resolve and bowel function to resume. So I think that's an important finding, and I'll talk about that more later. We looked at safety and tolerability of these medications. I think our team had a lot of concerns about the metoclopramide in particular. I know in the many years that we've been looking at malignant bowel obstruction and its management, I think it's come up multiple times, just anecdotally, not to use metoclopramide, that there's too much risk of bowel perforation. So that was something we were concerned about. Thankfully, we didn't see that. We only saw 2 episodes of bradycardia, heart rates in the 40s and 50s. Both of them were asymptomatic. They were caught on just monitoring, and that was attributed to the octreotide, and both patients' bradycardia resolved when the octreotide was stopped. For symptoms, I just want to highlight, the one statistically significant piece of data that we got from this was that all 13 patients who completed the study had resolution of their vomiting, regardless of whether or not their obstruction resolved. Similar, I think, to the results that the Berger et al. Team had back in 2016. And then survival. So our median survival overall was 89 days. Patients who remained obstructed was 54 days. Patients who de-obstructed was 114 days. And we can see there's a difference there, although that's not statistically significant, but there's definitely a difference there. And our 6-month survival was 20%. So what does all this mean? I think some of the key things and some of the key takeaways for me are related to, one, the momentum for the study. And I think this goes down to, our sample size, is that we started enrolling for this trial right before COVID hit and had a full year where we didn't enroll anyone because everything was put on pause because of COVID. And I think the engagement and the momentum that we had leading up to, the beginning of the study was really great. And unfortunately, a year later, it was a lot harder to sort of regain that momentum and energy for the study. So definitely, I think, contributed to our ability to enroll patients and really get the volume of patients that would show, more information, more clear-cut answers for some of these questions. I think another piece that's important to think about, and that wasn't really in the study, but I think is important, is, what exactly is the etiology of the obstruction, and what role does that play in whether or not it's going to de-obstruct? There's a portion of patients who will de-obstruct regardless, without intervention. The literature shows that. And my suspicion is that patients who have a less complex obstruction picture, maybe it's one site of obstruction, may be more likely to de-obstruct quickly than those that have multiple sites of obstruction. It's also interesting to think about what the mechanism of obstruction is in the first place. Is it because there's some external compression, or is it matting from carcinomatosis? Is it invasion of the bowel by the tumor itself? All these things may play into how an obstruction sort of goes and whether or not it's more or less likely to be resolved. We don't have any answers to any of those questions, but I think it's interesting to think about that. Sample size, again, we didn't have anywhere near the recruitment that we were hoping to have that would really give us, again, some clearer answers, or maybe some statistically significant answers, with our study. And then it leads me to the fact that there's more questions than answers. I don't think we know, how many, we don't know what the optimal medication regimen is. We don't know what the optimal dosing is. We don't know what the duration of treatment is. So, I walk away from this experience personally just being really excited to have been part of a clinical trial, and to have had the opportunity to work on this paper and to contribute to the body of literature in bowel obstruction. But I wish that there was more clear answers, but I definitely think there's a lot of opportunity here for further research, and a multi-center trial would be fabulous. And that's all I have. Thank you.
Thank you so much, Dr. Walter. Dr. Currow, I don't know if you want to talk a little bit about the use of octreotide, and then I think it would be great if we could have some time for questions, or even just a little bit of back and forth if you two want to discuss some of the choices in the study, or et cetera, that would be fine. I did want to just point out, Dr. Walter did let me know beforehand, she does not actually have access to the data for the study at this point. So we are not going to be able to get into the nuts and bolts of any of the actual data that went into this. So it's going to have to be more of a higher level discussion, which I think is more appropriate for this format anyway. So.
Great. Thank you so much for the opportunity to meet with you today. Really appreciate it. I turned up to a conference in Canada a few years ago, and the rapporteur for when discussing malignant bowel obstruction said, I wouldn't change practice on the basis of one study. And the rapporteur was referring to a study that a team with which I work published about 9 years ago. That study was a double-blind, placebo-controlled, randomized, multi-site, parallel arm study of octreotide and placebo for malignant bowel obstruction. That study was important for many reasons. Firstly, we actually recruited to our planned sample size of more than 100 participants. Secondly, it showed no benefit in terms of vomiting at 72 hours over placebo, and that was the primary endpoint. But importantly, let's be honest, I have been a huge fan of octreotide for longer than I care to remember. I think I first prescribed it, having argued with pharmacy about its supply in the late 1990s. And I have stood at the bedside of many, many patients with a malignant bowel obstruction, started them on octreotide, and when I've come back, they've said, I've still got abdominal pain. And I go, of course you've got abdominal pain. You've got a malignant bowel obstruction. But in our study, and this is why a placebo control arm is so critical, we learn not only the natural history in that arm, but we can compare to our intervention arm. And what we saw in the intervention was that by day 2, you were twice as likely to have had hyoscine-butyl bromide for colicky abdominal pain. And by the end of 72 hours, you were 3 times as likely on the octreotide arm to have required that medication. And we went back to look at the literature because that was a really surprising finding for us. And what we saw was a beautiful study from Japan that had followed people who had been started on octreotide very carefully. And they also reported an increase in abdominal pain. So the first point I want to make today is that everything we do has potential harms. What we've been really poor at in palliative care, because so many of our studies are retrospective and are observational, is attributing causality. And the reason for doing randomized double-blind studies, particularly when we're talking about subjective symptoms, and vomiting is not a subjective symptom, but nausea is, subjective symptoms, is ensuring that we can actually attribute causality. So we know something of the natural history of malignant bowel obstruction, but I agree strongly with Michelle that the number of studies we have where we've really followed people to understand what happens is incredibly small. It is a difficult to study population, there's no doubt of that, but we do have a systematic review that was published by Obita in 2016 about octreotide and lanreotide. And the thing that worries me, to be honest, is that that systematic review was then taken, as Michelle has referred to, by the Multinational Association for Supportive Care in Cancer and cited as level 1 evidence in support of octreotide or somatostatin analogs. In fact, the conclusion of that systematic review was exactly the opposite. And Jason Boland wrote a letter to the Multinational Association for Supportive Care in Cancer, challenging that level 1 grade A evidence because, in fact, it was 100% in the opposite direction. So we've got a number of open label studies, of which Michelle's is the most recent. It's great to be doing this systematically and prospectively. The challenge for me is, how do we really think about the outcomes of such studies? Firstly, we need to take an intention to treat approach. And so for me, the denominator in this study is 15 people, because 15 people were enrolled. And if we look at that, 8 of those 15 had a bowel motion. So in fact, one could suggest perhaps that the de-obstruction was in fact in just 53% of people. The next thing to say is that the patient populations were very different. And I think this is critical, and I agree strongly with Michelle that we need to understand what it means to have single level obstruction low in the sigmoid colon compared to peritoneal carcinomatosis, where you've got multi-level obstruction of small and large bowel. And in the randomized trial that I referred to at the start of this, 2 out of 3 patients had a gynecological cancer. That is, their chances of having multi-level obstruction was almost 100%. These were not people with a single level obstruction, and our survival data would also suggest that it was a less well population. Their median Karnofsky performance scale at study entrance was 50. And their prognosis was very poor. By contrast, I think in your study, Michelle, 2 people had gynecological cancers, and you comment in the paper quite rightly that seemed very low for such a high prevalence disease to have this. The next is when we look at multiple therapies at once. I love playing with old cars. And the thing that really astounds me about the great mechanics that I encounter is their diagnostic skill. They are great diagnosticians. In fact, they leave many of us in the medical profession, the nursing profession, and allied health for dead. And I've seen them work through problems. So as you think about that, they are just one thing at once. And one of our challenges is when we get to triple therapy like metoclopramide, dexamethasone, and octreotide, what's happening? Which of those is having which effect? And it's very difficult to tease out. And we don't have studies that have built sequentially towards that triple therapy. It's there based on empiricism, but we need to think about how we tease out the benefit of each of those. And octreotide and somatostatin analogs are incredibly complex in terms of their effect on the gut. You know, they have an opposite effect on large bowel and small bowel in terms of peristalsis. So what's the net effect? And what does that mean about the level of obstruction as we think about patients in this setting? So more recent work has really, from Alison Bravington, a couple of great papers on what should we measure as our outcomes. I agree that we're not sure yet. Clearly, resolution is great, but we know that resolution happens without any intervention in a proportion of patients, somewhere between 30 and 40%. Again, we've not been sophisticated in talking about whether that's single level, small bowel, multi-level, or single level large bowel. And we've got so much more work to do in this area so that we get it right every time for patients, the first time. And so the level of sophistication we need, I agree with Michelle, requires multi-site studies. In fact, I'd suggest transnational studies if we're going to do it in a timely way in order to really improve the care that we offer and the basis on which we offer it.
Thank you so much, both of you. Marty, I see that you did post a question, but I want to just, one stark difference that I noticed between the papers, and David, maybe you can speak to this. Your endpoint was only 3 days. And I guess when Michelle is saying that in their population, and again, there's a lot of things, the size and whatnot of the studies are very different, but when she's saying that they were usually seeing resolution at more like 6 days, that would tend to speak, in my mind, that a lot of it maybe was the steroids helping, right? That's going to take a little bit longer for the effect to be seen. So I guess I'm just curious if either of you have any thoughts about that distinction in the timing, the 3 days versus Michelle's population was looked at a little bit longer, and the results of the vomiting endpoint were seen later. And I wonder if that's something that's maybe just a little bit different, not necessarily based strictly on the drugs, but just the difference in what you all were looking at.
Michelle.
That's an interesting thought, Leanne, and I don't know that I've thought of that before. So that's a really great question.
Leanne, I agree that it's critical, and you know, having run a national collaborative trials group for phase 3 trials, the blood on the floor is always in the design stage. What's the intervention? What's a reasonable control arm? And particularly the duration of intervention has people very, very excited. So we do have a subsequent study, and in that study we were going out to 5 days rather than 3, but trying to get consensus amongst wonderfully motivated, engaged, thoughtful clinicians about those 3 questions in controlled trials is really, really difficult. And we shouldn't underestimate the amount of thought and, frankly, robust discussion, I think is the most polite term, that goes into defining some of those issues. And Adine, what are the endpoints? Is it vomiting? Is it de-obstruction? Really, what is it that we should be looking at? And we took the pragmatic view that that the patient's symptom burden was particularly poor, and that in our population, again, I think there are real differences between the populations of the 2 studies we're discussing this morning, and understanding those differences and really amplifying them in future studies is going to be critical.
Yeah, it's interesting. My background actually is in surgery. And so, of course, the adage with bowel obstructions, not malignant bowel obstruction, but bowel obstruction in general, is that you never, the old adage is you never let the sun set on a bowel obstruction, right? And of course, we know that to no longer be an accurate way to follow any kind of bowel obstruction. But with that sort of development and maturation of that approach over time, 3 days does feel short to me. And so that's just an interesting thing in looking at that, and especially seeing that in Michelle's population, it did take a little longer. So I would like to get to Marty's question really quick. He just said here that, David, you used to be a proponent of using octreotide in the 90s, as you were saying as well. Then you had your paper, and so he wants to know, what do you do now? And do you use octreotide, or do you try it if all else is failing?
I love the all else is failing, Marty, because we spend a lot of time criticizing our colleagues, particularly in oncology, when they say, I don't know what else to do. I'm going to give them fourth line therapy. And we go, oh my God, they're giving them fourth line therapy on what basis? And yet we do it all the time in palliative care. I think we need to think about both the physiology and the pharmacology of bowel obstruction. And I've got to say, again, we've tried to get up a study, and I'll be honest, have failed in looking at ranitidine in this setting. It does decrease gastric secretions really effectively, and if that's what we want to do, then it's an interesting study. And those studies have been done in anesthetics. Let's be really clear that they've compared proton pump inhibitors to histamine 2 antagonists in terms of the volume of gastric secretion. So we're not flying totally blind there, but we haven't recruited to our proposed sample size in that study by any means. So at the moment, yes, of last resort, but watching very carefully, particularly for worsening of abdominal pain, particularly in the setting of multi-level obstruction that involves small bowel.
And I think to me, that's one of my big takeaways from this, from this discussion, and also just looking at your papers. I really do think, Michelle, your point about a multi-institution study, and David, your point about possibly even having to be internationally based because of the volume. I think what we need is multiple studies for high obstruction, multiple patients with a high obstruction. And the only way to get that is going to be across many, many institutions, and then multiple patients with single site distal obstruction, multiple patients with carcinomatosis, to be able to really do subgroup analyses to look at where this might help. Because I think that's the key, because you look at the theory of each of these drugs and it sounds great, right? That's where I think we all fall into that trap of, well, octreotide should do this, and metoclopramide is going to do this, and the dexamethasone does this. And so you really want to capitalize on all of that theory. And as you've both mentioned, we just don't have the studies to support necessarily that's what actually happens in not in the theoretical world, in the actual practice of what happens. So I am not seeing any comments or hands raised. Anybody with any other questions, or Marty, anything you're still wondering? I could go on for hours here, but I know we're close to time here.
So, David, if I can just press you a little bit more. I think I heard you say, if you were faced with a malignant bowel obstruction in the hospital today that you had to manage, it's today's Saturday for you, on Monday, when you're back in, it sounds like your go-to, more likely than not, might be ranitidine, maybe dexamethasone as your sort of initial go-to, and something like octreotide. You'd be hard pressed to do something like that, but maybe if all else fails, as that fifth line chemo agent. Does that sound about right?
Yeah, look, sadly, Marty, I have to say that does sound about right. And, on what are we basing that? Very, very little.
Fair.
I think what we do have are two large controlled trials of octreotide that really call into question their symptom relief benefits. We can only take the evidence that's there. We all want it to work. We're all willing it to work. But the reality is that we don't have evidence in support of it, and we have explicit evidence that says it adds to symptom burden. We continue to do some very strange things in palliative care when you think about it. This has always been a drug looking for its cause in palliative and hospice care.
I know that I work with some oncologists that will cite some of those expert consensus recommendations that recommend octreotide that maybe don't get into the weeds. And I think it's so important and valuable for us to appreciate what the level of evidence really is. So that way, when somebody else might be recommending it, we can at least speak to what the gray area that we're really working with. The uncertainty.
So to that end, I commend the letter to the editor of Supportive Care in Cancer by Jason Boland, because I have no idea how they got to level 1 grade A evidence. It's just not there in the literature. It's exactly the opposite. So it really is a challenge for us, as you say. People read the top line, they get halfway through the abstract, and that's it.
Well, and to be fair, on all accounts, if we wanted to imagine a world where there was really robust evidence saying that octreotide worked, just bear with me for a split second here. But if we started it in a patient and we noticed that their symptoms got worse, we probably should stop it anyway. So at the end of the day, we should, again, given that we don't live in that world where there's solid evidence for every type of situation we're going to encounter. I love, David, that you were saying that when you do use it now, it is with a very close eye for any worsening symptoms. And I guess that's my biggest takeaway from this, is that, there's evidence saying it's probably not great. There's evidence saying maybe it helps, that we need to explore this more and figure out maybe what the right population is for it to be used. But at the end of the day, we should really be watching closely, because there's also clearly evidence that in some patients it's going to cause some additional abdominal pain, which of course is the opposite of what we're trying to do. And so if we're seeing that, that should be a flag to watch for, and not attribute it to disease, like we've kind of tended to do, and like we often do in palliative medicine in general, because we are dealing with accelerated advanced disease state. So I think, to me, that's my biggest takeaway from this, is reminding us to get back to those roots of, is it actually making the patient feel better? If that's really our goal, is palliation of symptoms, are we actually seeing that? So I think maybe that's a good place to end. Any other questions, comments? I see Marty's putting the thank you, and I want to emphasize that as well. Michelle and David, thank you so much. We're so grateful to both of you to be, yes, absolutely, to be a part of this discussion. This was really a great talk. And again, I was grateful Marty let me do this one with my surgical background. This is near and dear to my heart as well. So thank you all very much. And we'll see you all next week. Enjoy the weekend, and hopefully nice weather for everyone. Take care.
Have a great day.
Yeah, thank you so much.
Thank you.